Hello, good evening, everybody. My name is Alec O'Dare. I'm the Managing Director for Urology Continence Care today. This evening's session is Percutaneous Nephrostomy, Optimising Care for Patients. And I'm joined by the wonderful Jenny Akins, who is a Urology Advanced Nurse Practitioner at the Royal Wolverhampton NHS Trust. I'm going to come over to Jenny in a moment, but first I'd like to thank our sponsors for the evening. So that's Bourne and also Manfred Sauer. So thank you very much to both of those organisations, and thank you very much to everybody that is joining us this evening. Please do ask as many questions as you like throughout the presentation in the comments section. We'll be coming back at the end of Jenny's presentation to answer as many of those as possible. Do also let us know where you're viewing from. That's something that we're always very interested in. Certificates, as always, will be available at the end. There'll be some links that my colleagues will share on there, so you'll be able to download a certificate for your revalidation for your CPD folders. You'll see that we're presenting still from our homes, so if we've got any technical issues, do please bear with us. Jenny, are you there? Let's just check technically that you're with us.
Hi, can you hear me okay?
I certainly can, which means that the audience can as well. Jenny, this is your first event with us, so I'm very much looking forward to the presentation. This is a subject that we've not done before, and I know that from looking at the slides, it seems really interesting, and I'm certainly very interested in learning more about it. Jenny, I'm just going to wish you good luck at this stage. Hand over to you so that you can do the presentation. I'll be watching along with everybody else. I'll come back with the live Q&A at the end. So it just leaves me to say to the audience, please do enjoy this evening's presentation, and do remember, ask as many questions as you can. Good luck, Jenny, and I will see you very shortly.
Thank you. Thank you very much for that introduction. So hello, I'm just going to bring up my slides, so just bear with me. So good evening, everybody. So I'm going to be talking to you about nephrostomy care, and I'm really passionate about the work that I've been involved with. And this session is going to help you whether you are a complete novice in nephrostomy care, you'd like to expand your knowledge further in this area, or you're really struggling with your service or managing this cohort of patients. Like I said previously, there'll be an opportunity to raise any questions, and at the end, I'm more than happy to share any work that I've been involved with. So let's press ahead. So the learning objectives for this evening, so these include what a percutaneous nephrostomy is, and the types of nephrostomy tubes, drainage bags used, possible complications of the procedure, care of the patient with a nephrostomy, why and how a working group was established, and resulting changes in practice and their impact on healthcare professionals and patients. And before moving on to the next slide, I just wanted you to think about the last person or patient that you were involved with nephrostomy care, and how you felt about that experience. Did you feel particularly anxious? Were you confident? Were you well supported? And what went well? What didn't go so well? And I just want you to keep that in mind throughout this presentation and reflect on that throughout. So the first question is, what is a percutaneous nephrostomy? So this is a minimally invasive technique where a drainage tube is inserted into the kidneys across the skin surface, which diverts urine. This procedure is performed under image guidance, and it's usually a combination of ultrasound and X-ray guidance, and is most frequently performed in the radiology department by a specialist trained consultant radiologist. Most patients will have this procedure performed under a local anaesthetic, possibly with sedation or analgesia as required, but very occasionally this procedure can be performed under a general anaesthetic as well. So percutaneous nephrostomy tubes are a sterile drainage device. and they are associated with serious risks. And just have a look at this statistic. So 1 in 100 patients are at risk of developing a serious infection, and approximately 2 in 1,000 patients are at risk of death. And therefore, it's so important that we ensure appropriate measures are taken to minimise these associated risks to our patients. So why is a nephrostomy tube inserted? So these devices are required due to a blockage or damage between the kidneys, the ureters and the bladder. The most common reason actually is to decompress an obstructed kidney. Other reasons can include reducing the urine flow in patients who have had an injury to the ureters, perhaps during surgery or through trauma. You may see a patient with a nephrostomy if the patient has had an antegrade ureteric stent replacement, stone surgery or extraction, or other intervention on the kidney in urology theatres. So why do obstructed kidneys need to be drained? Well, obstruction can lead to the kidney no longer function as well as it should. An obstruction can be associated with infection, which can lead to serious risk for the patients. And also it can be extremely painful and uncomfortable if that happens acutely, and it could lead to a rupture to the collecting system. So what are the causes of an obstructed kidney? There are multiple causes that can occur at any level in the urinary tract. So normally urine drains from the collecting system down the ureters and into the bladder. As you can see from this slide, there are various causes at each level at that drainage system. An obstruction can occur within the kidney itself due to a stone within the kidney. It can occur due to a blood clot travelling down the ureter. It can also occur if there's any damage to the ureter during surgery or following extreme trauma. Bladder cancer, so transitional cell carcinoma or tumours in the bladder can obstruct the ureter. So right at the bottom of the region of the vesico-ureteric junction, the blockage can occur there as well. Certainly if the bladder isn't emptying properly and it becomes high pressure, that can stop the kidney drainage. Other causes are tumours in the ureter, congenital obstructions, masses or lymph nodes within the abdomen, and that can cause compression, which can lead to obstruction. And as you can see, there are multiple causes, and this list is certainly not extensive, but a nephrostomy can provide a solution for all of these problems. So moving on to different nephrostomy tubes. So there are different nephrostomy tubes, and it's important to clarify the differences. I'm just going to talk about my experiences and the ones that I've come across in my trust. So you may have come across different nephrostomies where you within the place you work. So the standard shape of the tube that goes into the kidney is called a pigtail drain. And you can see from this image why the tube has that name. Generally, a nephrostomy tube that is inserted in radiology will have the luloch at the one end and the pigtail formation at the other. So the luloch tube will require a standard luloch drainage bag. So these differ from a catheter drainage bag. The tip of the nephrostomy is very important in terms of drainage, in that the pigtail shape is very protective and non-traumatic inside the kidney. And there's a hole throughout the centre of the nephrostomy, but also there's several holes at the end of the pigtail. And this aids drainage of debris, thick urine, and minimises obstruction. This type of nephrostomy is a standard non-locking pigtail drain, and this type is very frequently used. So moving on. So another commonly used a nephrostomy tube is this one, which is very similar in shape to the previous one, but this has a locking mechanism. So the locking mechanism consists of a small stitch that goes through right through the way and down and exits the other end of the distal end of the nephrostomy via the pigtail, and you should just be able to see this and on this diagram. Once the nephrostomy tube is in situ, it is pulled tight and it coils the pigtail. And at the other end, by closing down the lever at the Lulock end, it holds the stitch in place, and therefore that curl remains in place inside the kidney. It's locked in place and it just can't come open and come free. And the advantage of this type of tube is that if it gets tugged or if it's moved when the patient is being transferred, it's much less likely to get displaced. This is more stable nephrostomy tube, particularly for patients who are going home with long-term nephrostomy tube. And if this needs to be removed at all, it's a matter of unlocking the lever, so opening the lever, unlocking and straightening, opening the tube using a guide wire to open the stitch back up, and then you slide the nephrostomy tube out. And my advice is, if you have any doubts of what type of nephrostomy tube that you're dealing with, it's best to contact the radiology department. Please do not try and pull it out, because if it is locked inside the kidney, this will cause significant trauma to the kidney. So it's also very useful to be aware of this type of nephrostomy tube. This is called a Munich drain. And the Munich drain doesn't have a pigtail. It's a long, straight tube with has holes throughout the whole length of the drain, which allows drainage. It has a firm plastic disc at the top end, and it fits flush to the patient's skin. And I've actually got one here to demonstrate it. So as you can see, this is the internal section. So this would go into the loin and directly into the kidney. And then this section fits flush onto the patient's skin. As you can see, there's several holes in the disc, and then this is sutured to the patient's skin. And this comes in two parts. So that is the internal section, and that's sutured. And then the external tubing is this clear tubing here. This clips on just like that. And then this is attached to your nephrostomy drainage bag, and this is a Lulock end. And the advantage of this two-tier system is that if this external tube gets broken or cracked, or it can actually be taken off and replaced. And the advantage is also that if the patient tugs on and pulls this, then it will just take off this external cap, and I'll try and do it. So it will just take that off. So that stays in place. So there is an advantage of this, and it's very useful because, like I say, the cap and the connector can just be clipped on and off. But what really needs to be carefully considered is the patient's skin. So you really need to do a skin assessment for these patients. There's a potential for infection and injury to the skin. And if it needs to be removed, it's very simple. The sutures are cut around here, and then the drainage just simply removed very easily. So yeah, that's another drain for you to be aware of. So fixation and drainage bags. So going back to pigtail nephrostomies, there are very many ways of fixing a pigtail drain. And the fixation shown on the left picture here, we call it the butterfly dressing, as you can see why. And the adhesive will attach to the patient's skin, and then the tubing will be sat in, and then the clip goes over to secure the nephrostomy drain in place. And this again, just to make sure it doesn't get pulled or tugged. And what you can do is either over or instead of this type of fixation, you can use a gauze and clear film waterproof dressing, which I would advise to use. When changing the dressing, it's very important to be extremely careful to support the tube throughout it so it doesn't get pulled or dislodged. And certainly don't use any sharp scissors around the tube, because if the tube is cut, then this is a really poor outcome for the patient as they have to go back through that procedure again. The picture on the right here you can see is a standard loo lock drainage bag, and these are applied within our trust in the radiology department after insertion of nephrostomy. Again, a loo lock drainage bag, and this is secured with the straps onto the patient's waist or leg. And again, good security to prevent it from dislodging. So insertion, possible complications. As I stated earlier, percutaneous nephrostomy does carry significant risks. The main complication that can occur following a nephrostomy insertion is infection. Hemorrhage as well, because introducing a needle and a tube into the kidney, which has a very large blood vessel supply. Damage to other organs, so the kidney is very close to the lungs, the liver on the right side, the spleen on the left, and also the bowel. So there is a risk that these organs can be punctured by accident during the procedure. It is important for the kidney as well, and it is possible for the kidney to drain as well around the nephrostomy, and this can lead to a urine leak. But any of these complications can be potentially serious or life-threatening. And it's for that reason we need to be very careful, not only about the way we prepare our patients and go through the consent process with them during the procedure, but really about the way we look after them after the nephrostomy has been inserted. So what are the key things to look for when a patient has a nephrostomy tube inserted? So most common complication is an episode of infection or sepsis after the procedure. There is a particularly an issue if the patient has already had an infected kidney. And if you can think about it, once you start instrumenting the kidney, and it's infected, that can increase the risk of septicemia afterwards. Bleeding can occur as well, because inserting a drain into a vascular organ and potentially crossing blood vessels. So it's important to be very alert to the risk of serious or life-threatening bleeding. It is very common, however, to see blood post-procedure, and normally this would clear very quickly. But heavily blood-stained urine in the bag that's persistent and it's not normal should be raised within the medical or radiology team. And again, I would alert the medical staff if a patient is suffering from increasing pain, becoming unstable with excessive bleeding around the insertion site. Blockage is a very common occurring theme within the nephrostomy tubes. And if there's no urine output, my first thing would be to check for any kinking within the tube. It's before you alert the medical team. It can be something very straightforward. A patient's just lying on the tube, or it's just kinked in under the bed sheets. So just check for that before you alert the doctors. Also, look at the drain. As you might see, the pigtail of the tube markers or the holes outside the skin surface, and that would mean dislodgement. If that has occurred, interventional radiology will need to be informed as quickly as possible. So on this slide is the post-operative care plan that we use within our trust, and this is sent back with the patient back to the ward. I'm not going to go through it in detail, but it certainly outlines the observation that will assist picking up complications as early as possible. Certainly escalate any concerns to the medical or radiology team if you're concerned with any post-procedural complications. The other golden rule is always support the tube with care when you're moving the patient, and again, avoid sharp instruments around when cutting the dressing or around the tube, because It can, again, be very distressing for the patient if you cut the tube, and again, they need to go back to radiology and have the whole procedure done again, and have the associated risk factors involved with that as well. So nephrostomy drainage bags supplied in hospitals vary, and some are not widely available in the community. And they're often not designed to be a comfortable body-worn product. An example of a comfortable body-worn product is the Manfred Sauer Nephrostomy drainage system. And the Nephrostomy system is available on FP10 community prescription. So, you know, again, look at what you're using within your trust. But this is the bag that we commonly use within our trust, and it is a very good designed bag. On this slide, you can see the actual Nephrostomy bag and what it looks like. The Manfred Sauer have a range of resources on their website and a step-by-step diagram of how to apply this system. And I certainly would advise that you go and have a look at their resources on their website and, you know, download or print off anything that you need. So certainly use the resources available. So moving on, the next thing I wanted to talk to you about was the work I've been involved with and why really that occurred. So essentially, a working group was formed within the trust I work for, and that was following two very serious incidents relating to nephrostomy devices. And the objective of the working group was really to review the current practice and formulate a nephrostomy policy. We also wanted to develop a database. And what we did in the working group was did some process mapping. So we looked at the service as it was when we first set up this working group, and we mapped out what we would like the ideal pathway to look like. In the initial meetings of the working group, we really established and raised lots of concerns additional to those for a few objectives that we initially went out for. So we were particularly concerned about the tracking of patients following nephrostomy insertion. So, you know, the nephrostomy would get inserted in radiology, but the patient would return to any ward within the hospital. And we really didn't have any knowledge of those patients. There was a lack of knowledge and confidence in managing and implementing nephrostomy care. There was no real contact information for both patients and staff of where to go to for assistance and help. It was acknowledged there was a variation in nephrostomy education given to patients, and this was dependent on where the patient would be staying following their nephrostomy insertion. And there was no direct access to support and services. What really became apparent very early on, there was no ownership of the cohort of patients, so they're not all urology patients. And the patients had a poor experience with inadequate standards of caregiving, and also poor discharge into the community setting as well. So there was lots of areas that we needed to address. So the working group, the success of the working group that I was involved with was because we had a multidisciplinary approach to it. So we had a program partner, continuous quality improvement team, and the lady that was involved with our team, her name is Louise, and she's such a valued member and really helped to drive this forward. We had key representations and members from renal, radiology, community, surgical emergency unit and oncology. And again, this really enabled us to move these services forward fairly quickly. We also had additional support from medical illustration, ratification team and infection prevention team. We had regular fortnightly meetings, obviously apart from the break during COVID. And these key members, again, have been the driving force for this project and really moved this project on. So then the next thing we really want to do was implement a change in the service for the patients. So we had a complete revision and provision of care. What we wanted to do was avoid admission to emergency departments, as patients are waiting in the emergency department for several hours and getting lots of different care and advice. So we wanted to try and avoid that. So what we implemented was that any healthcare professional could contact the urology clinical nurse specialist team for support and advice. We also were offered patients to self-refer to us. So if they're unable to resolve their problem with a district nurse or practice nurse, or their ward staff could contact us. And as a urology team, what we would do is offer verbal advice and assess if the advice and guidance was adequate and just document that. Whether a face-to-face clinic with the urology team was required for any further intervention, and arrange for those appointments to be made, and set up what we call a hot clinic, so we could see the patient on that day. And if there was further complications that couldn't be managed in the outpatient setting, such as dislodgement or a risk of infection, then we'd arrange direct admission to the surgical emergency unit. And out of hours, we would use the surgical emergency unit. So weekends and after 4:30 until 8 o'clock in the morning, the patients and staff again could ring the surgical emergency unit directly for any advice and guidance. So additional to the changes to the access of provision of care, it was also important for us to improve the education and resources. So over the past year, the team has produced a series of resources that I'm going to share with you. And all these resources are now available on our Trust intranet under a nephrostomy hub. The work to produce these resources has been phenomenal. And again, the multidisciplinary approach and the commitment to the team has resulted in the success of this project. It certainly has been a team effort. And the Nephrostomy Hub aims to give healthcare professionals access to a range of resources, information to enable them to provide optimum care and support for patients. So part of the expanding knowledge base, we have produced a range of educational videos for the Nephrostomy Hub. This is just a screenshot of a video that's available on our Trust intranet site. And you can see Dr. Mike Collins here, who's our consultant radiologist, and he gives a really informative overview of percutaneous nephrostomy. I can't speak highly enough of him. It's a great little video. And again, for somebody who's new or just wants a refresher or just not sure about types of nephrostomies, again, it just gives you an overview. It lasts about 25 minutes. And it really is particularly helpful to expand your knowledge in this area. And so it's available for all our staff to view on the intranet. Included in the hub are clinical education. So it's also important to support healthcare professionals when performing a clinical procedure involving nephrostomies. Therefore, we produce 3 clinical nursing procedures, and this is to cover changing a nephrostomy bag, changing a dressing, flushing a nephrostomy tube, and these are step-by-step guides on how to implement these following ANTT. And attached to these are competencies assessment tools as well, so the nurses can achieve competency-based assessment until they feel they're safe to do this independently. So these have been really helpful to put on the intranet. So to support these clinical practice further, we also produce clinical educational videos to be used in conjunction with the written clinical procedures. And these visual guidance enhance the nurse's confidence in knowing that they're performing these activities accurately. We have also produced a video of how to apply a Nephsis bag as well in the belt system, as this can look a little bit complex when you open the bag and you see all the equipment involved. So again, it gives you a visual aid on how to apply this. So if we get a phone call and somebody's on the ward and they're not sure what to do, we can direct them to these videos. They can watch it, they can read the clinical practice, and this will really enhance their knowledge and, like I say, give them empower them really to be able to take out that procedure. So moving on to the troubleshooting chart. So this chart was developed for healthcare professionals to support staff in both acute and community settings. This is broken down into 3 key areas. So you've got the red, which is your problem, the amber, possible cause, and the green, the action. And really, this chart offers guidance when problems occur. So it empowers staff with their decision making. And we have hard copies of this in clinical areas, so treatment room. So again, if they look at a patient, or what's the problem, they can look at this chart. What can I do? What do I need to do? And hopefully it just gives the healthcare professionals a step-by-step guide. So this is the top half of the form. And moving on to the next slide, this is the bottom half of the form. And the bottom of the form also gives contact details for healthcare professionals if they can't solve the problem or they're not happy to proceed with the intervention. Then the contacts for the urology CNSs, surgical emergency unit on there for further advice as well. So this is a discharge form. So this form was produced to ensure that all elements of care are completed and performed when the patient is discharged from hospital. This checklist is signed once all the actions are completed, and a copy is sent to either the district nurse or the practice nurse. And this provides a safety net that all appropriate referrals are performed and the patient's received all relevant education and resources prior to discharge. And it's just giving like a safety net to ensure that the patient is going home with everything they need and the right education. Very simple to do, and again, it's really enhanced and improved the discharge process. So this is a home delivery form. So this is a clear and concise form with pre-printed products documented on it. And it makes the process of referring patients to for the ongoing nephrostomy products really easy. So the patient's details are inserted and the GP details and any additional comments on the form. And then it's emailed to the delivery service to action the supplies. And again, it prevents any unnecessary delays in the patient receiving the required products when they go home. And I just find if you make things very simple for the nurses on the ward, because they're so busy, things will usually get done if they know it's just a quick sticker or inserting a few things. So just make things standardised and easy for the nurses because they have so much paperwork to fill in. So the nephrostomy passport produced from Manfred Sauer is another really useful resource. And this patient handheld document aids communication for healthcare professionals, and it can highlight recurring problems. It's also as a helpful guidelines for patients when problems occur for themselves as well. You know, like I said before, Manfred Sauer have a great range of resources that are available online and to order. So don't reinvent the wheel. If you haven't got any resources within your trust or you're really struggling, you know, go to their page and see what they've got, because that could be a really good start for your unit. Alongside these resources discussed on the hub as well, we've got some links for help and support, some key care points, so like just a bullet point of do's and don'ts with patients' nephrostomy. So it's a quick little reference for the ward staff if they're not sure what to do. And again, the contact details are on there. And these are not just for acute, they're for community settings as well. So if somebody's in the home and having problems with the nephrostomy, there may be a link in the community that they can use for further advice and guidance. So what I wanted to do next is just let you just read the next 4 slides yourself, and these are quotes. So the first 2 are from healthcare professionals and the last 2 are from patients. And this is really for you to just see how much this work has impacted on the patients and staff. So what next? So what we want to do next really is to continue to promote and share work locally and nationally. Utilise the resources further within the trust using the practice education facilitators. And certainly we do want to audit our practice further to look at what's happened with the emergency department admissions and patients that we've admitted to surgical emergency unit. I certainly really want to write up the work that we've done, and that's something I've been started on, and you know, obviously publication. And I really want to work with Bound further as well, and you know, certainly looking at some national guidance for patients with nephrostomies. So so moving on to the conclusion. So all healthcare professionals should be committed to prevent avoidable harm and minimise associated risk to patients who require percutaneous nephrostomy. There is a requirement to provide necessary resources and increase awareness and understanding of how to care for patients with a percutaneous nephrostomy. Patients should be able to have access to specialist support, advice and treatment in line with stoma care in both acute and community setting. That's something I'm very passionate about. Certainly striving to improve and optimise the provision of care nationally results in better outcomes for patients. And like I said at the beginning of the presentation, just think about the last patient you dealt with a nephrostomy, how you felt about that situation, what provisions of care you'd like to have in place, and what you would change if you could do that episode of care again. So just think about that again. So further reading. So you can see here there's 2 further reading, and also the European Association of Urology Nursing do have an online course. It is for members only, but it is there, and it's a very cool course. I've done that, and there are my references. So many thanks for listening to me. I really hope you found this session useful, and I look forward to hearing your questions.
Thank you, Jenny. That was very informative. I've been watching some of the comments that have come through. We've had hundreds of comments and lots of questions. So it's clearly something that that people are very interested in. You just mentioned at the end, actually, something that I was going to ask you, which is, you know, what are the next steps for this? And sort of taking it nationally is something that I thought was going to be my question. Is that the plan? What I'd love to hear actually is from the audience is to whether anybody else nationally has anything similar. If they could let us know whether there's any sort of whether there's any specific guidance in place that is even close to this, because this is obviously very very clear and comprehensive guidance, and it sounds like as though you're probably ahead of the curve, really, from a national point of view. So well done on that, and yeah, look forward to seeing whether you can roll this out nationally. I'll be keeping a very close eye. I'm not going to talk too much. Usually I ask lots of my own questions, but there have been so many that have come through from the audience. I think we should just get straight onto those. So I'm going to ask you the first one, if that's right. The first question is, how frequently are it says the nephrostomy? How frequently are the nephrostomy bags changed?
So our guidance is weekly bag and dressing changes, unless it's clinically indicated to do it more often, particularly with the dressing. If you've got a wound issue, you might want to do that frequently. But I would recommend weekly bag and dressing changes, and that's in our clinical practices. I don't know whether anybody else has got any viewpoints on that, but certainly that's what I would advise. Okay.
Thank you. Question number 2, could there be issues around the site on the skin, and what's the best way to manage this? I think you probably just touched on that a bit with wounds. What do you think of that?
Yeah, so that's under, like, say, the troubleshooting chart, and yeah, it's I would recommend that you would do a skin assessment like you would with any skin. So you look at the skin, you would swab it, you would dress it. If you need to make a referral, you look at that. If you need some further advice around the area, then seek that advice. But certainly, like any other skin management or wound management, you need to inspect the area carefully and raise concerns. If you think the patient would need a course of antibiotics, speak to the medical team. But certainly I would swab the skin site, obviously clean it, change the dressing using ANTT. If you need to take a photo of the area as well, contact a clinical illustration to take a photo. So just raise it and obviously document it. Important documentation. Document your concerns and what you've done.
Brilliant advice. Number 3, can you explain the maintenance using flushing?
So yeah, I've been asked this before actually, whether what my thoughts are on maintenance flushing of nephrostomies. I'm not overly keen on maintenance flushing. I think if you flush a nephrostomy tube a few times, then you need to question, is there a problem with the placement of the nephrostomy? So I don't think that would be something I would commonly do. Again, I would be interested to see whether there's any other thoughts about that. People are on the call, but I personally would not recommend it. I think you start introducing fluid into the kidney, or you continuously disconnecting it from the bag, you're risking infection as well. So you've got to be really mindful of that. So I would flush only if there's a blockage once or twice, and then I'd probably escalate it after that to the medical team or radiology.
Okay. Next question. Can people self-care with this? Can family members or carers be taught how to change the bags and care for the skin, etc.?
So yeah, we've actually taught. We've got a couple of patients with long-term nephrostomies. They're never going to be removed. They're in for the rest of their life, and we've brought them up to a clinic appointment and show them step-by-step guidance and give them the clinical practices, showing them the videos if need be, and run through it until they're happy to do it independently. Obviously, would never enforce a family member to do it. It would be from their choice. But yeah, we have done it. But it's about making sure it's the right thing for the patient and carer, and giving them the right support as well. So if they ever retracted on that, then you could step back in as well. So, it's having that little bit of a contract with the patient and the carer to say, we're here to support you, and give them as much guidance and support as they need. Okay.
The next one is, it says, are there any booklets or information leaflets that you could recommend that are available to give to patients? I know you said that you've got some on your intranet, but I wonder whether there's, for people who are outside of your trust? Is there anything that you're aware of that perhaps we could stick some links onto later or put onto our website for people to download?
Absolutely. So, I mean, we've developed some of our own booklets within our trust, but like I said before, the Manfred Sauer ones are absolutely brilliant. They're really well illustrated. They're nice glossy passports and information leaflets. And they've got a lot on their website. So visit, have a look what you need. Like I said to you before, don't reinvent the wheel. Look at what the resources available and get some supplies in. If it's going to help patient care and help your staff members, it's very good as well for the passports. If it's like sort of highlighting issues, reoccurring issues as well. So I would use a passport for patients with long-term nephrostomies with that you're going to probably come across some issues with them, but go and have a look at the resources. Okay.
I will. We'll speak to Manfred Sauer about seeing whether we can get links available. I think that there certainly are going to be some links at the end of the presentation to both I say born, you said bound, didn't you?
Well, you know what? It's a north-south divide, I think.
Yeah, I'm from South Wales, so it's born for me. I'm sure some of them are listening, so perhaps they can tell us which one of us is right. But we're going to be putting some links to both the born/bound website as well as Manfred Sauer. So I think there will be you'll be able to access any of the information that is available via their websites. Just as a slight aside, I actually met the team from Manfred Sauer today at the ACA in Bristol, and it was the first time that I met them. So hello, if you're watching, it was lovely to meet you. You're a very, very lovely team. So anybody watching, do go visit their websites. Next is what is the average time a nephrostomy drain is left in situ?
So it would be dependent on the reason why it's been inserted, but they do get exchanged. So again, I would consult your team to get some guidance and what their expectation of that time the nephrostomy tube should be in. And also when the exchange has been booked in as well. So it might be that they've had intervention for urology conditions such as a stone, and it doesn't need to stay in very long. So again, get clarification, and that really needs to come in before they go home as well. So you've got a plan in place when it needs to be removed, what the action plan is. So again, document that and make sure you're aware of that.
Okay. So the next question is a drain fix dressing acceptable to secure the nephrostomy tube to the skin? And how much movement of the tube at the exit site is acceptable before seeking advice?
So yeah, just do your best. I mean, like I showed you the butterfly dressing, which is what is used within our trust following insertion, but sometimes they do get a little bit soiled, or they need actually to be removed. And unfortunately, we struggle to get a replacement for that. So we would then move on to a gauze and take sort of a clear film dressing to apply. But as long as your dressing is secured, that's fine. Just obviously, what I said before, is just look out for those markers on your nephrostomy. If you can see the markers and you feel it's being dislodged, it's not draining, that's when you would need to alert the radiology and medical team. But if it's secured well and you're very careful, it's really being very careful when you take the dressing off, is really holding that tube in place so you're not likely to tug and pull on it. So but we, like I say, we use gauze and clear film dressing for majority of our patients, and we generally don't have an issue. It's just passing that really knowledge on to community nurses and district nurses, just saying, just be careful on changing of the dressing. I have come across a patient recently, and actually every time they had the dressing change, they had a little bit of a blockage, and it was because the tubing was kinked under the dressing. So it was a really easy thing to alter and change, but we needed to communicate that back to the practice nurses, just be careful. So just take care and you should be fine.
And are they specific nephrostomy dressings, or do you use general?
No, so like I say, the butterfly one is the initial one. I think there are some that you can order, and like I say, different trusts may use a different fixation, but generally we move over to gauze and a clear film dressing. But there are probably other products available on either prescription or to be ordered in the hospital. So again, you would need to find that out within your trust.
Yeah, okay. Next question. We've got still got plenty more, and we've got a bit of time left, so we'll get through as many as we can. And as always, if we don't get through to your question this evening, do still keep sending them, because what we'll do at the end of the presentation is we download them, we put them all onto a document, which we'll then share with Jenny and with Bourne and Manfred Sauer, and then we'll get the written answers to those questions, and then alongside the presentation on our website, we'll put a document with all of the question and answers on them as well. So so apologies if we don't get directly to your question this evening. We will endeavour to get back to you at some point. The next one is, are nurses allowed to flush nephrostomy without doctor's orders?
We do it as a specialist nursing team, and we use obviously advice from the troubleshooting chart. So if a nephrostomy is blocked, again, we've got some little key points saying look for infection. So if it's infected or you suspect infection, I wouldn't flush a nephrostomy. But we do within our trust. I think, again, that's something you probably need to seek advice regarding within the area you work. But I think if you follow guidance, you can do it. And again, we've got clinical competency-based so you can go through a competency-based practice till you feel that you're adequate and you're able to do that procedure. But we'll do with it. But obviously we're urology specialist nurses, but the community nurses can do it. But I can't see why, if you think it's blocked and there's no other cause, then you could flush the tubing if you follow a clinical practice.
Okay, thank you for that. The next one is about the Munich drain. It says, if the Munich drain external tube is disconnected, can we automatically put it back, or do we need to replace it with another sterile external tube?
So it comes as a set, so like that, so the two parts are together. So you would just need to phone radiology and get the set. Obviously you wouldn't need that section, which is the internal section, and then you just clip on the external section back on. So that's what we would do in our department, is just ring radiology, ask them for a Munich drain set, and then the outer tubing would just then be clipped on. So you just discard that part.
Yeah,
that makes sense.
We talked about whether it gets disconnected a few times. Is that something that happens often then? Yeah,
unfortunately, yeah. So disconnection, dislodging, the nephrostomy is being pulled out. You know, it is a common occurring problem. And again, it's about education, about securing the nephrostomy tube well. And again, like with during dressing changes, making sure it's done safely and not, like I say, not using scissors, not pulling on the dressing inappropriately. So just taking a bit extra care.
Yeah, I've been pulling the tip out the end of my pen ever since you said it. It's just slips back in. I've been wondering whether it was that sort of strength, or maybe there's
this one's quite
Yeah, so is it difficult to do? I've not seen it. Is it fairly difficult to do, or is it?
I mean, yeah. And to be honest, you'd be talking on that skin, so I'd be concerned, because like, look, if I do, it's a bit of a pull, but it can happen. Yeah.
So it sounds a lot more secure than what we've been talking about.
Yeah.
The next one you've actually mentioned, somebody has actually asked the question that we talked about at the beginning, and something you mentioned at the end of your presentation, which is, are you planning to roll out this troubleshooting guide nationwide? So I think we know that the answer to that is as part of publication, as part of auditing and things like that. That would be the next step. So that's very exciting. Let's have a look. Next one, are there red flags to look out for? If there are any issues, who should they contact?
Yeah, so like in my presentation about post-operative complications like bleeding, infection, excessive bleeding around the site or in the bag, they would need to be escalated. But, you know, just, you know, as nurses, you do look at, and you know when something's not quite right with a patient. So you might have sort of your observations checklist, but you just sometimes know with the patient that something's not quite right and just escalate it. But yeah, if you go back to my sort of presentation, you've got a list of all the complications, post-procedure complications. Just go through that really.
So would we be saying then that because that doesn't really specify, we don't know who, the type of nursing role that
Yeah, yeah.
If they're a district nurse, would they then have access to refer directly to the urology nurse specialist?
Absolutely. So if a district nurse was seeing a patient in the community, or a practice nurse, and they weren't happy with the skin site, or they were concerned with the patient was having an episode of sepsis, or their nephrostomy was discharged, or it wasn't draining properly, we could bring the patient in either via the outpatients department, but generally if we're concerned and it sounds quite serious, we would admit them directly to the surgical emergency unit, so they could get a direct assessment, and if they needed antibiotics, that could be implemented very quickly.
And is it as easy to refer from a community setting? Because the next question is actually about care homes as well, so we'll get onto that in a moment, but is it as easy to refer from a community setting, whether that's care homes or from people's homes, as it would be, or as I'd imagine it would be if it was in a hospital?
Yeah, I mean, we would accept referrals from any healthcare professional. So if they had concern with a nephrostomy, and because obviously the seriousness of this device, it needs to be actioned quickly. And like I say, for a district nurse, or it was a nursing home that had concerns with the patient, again, we could bring them up if they were, or like say, directly admit them. But yeah, they have got links, and we've got links in the community. So I've got some links to very senior, some matrons in the community as well that have been involved with this project. And those links are really helpful because I can speak to her directly if she's got a patient with reoccurring problems with a nephrostomy as well. So this working group has really helped because we can communicate with the right people that need to be involved, like radiology, community, matrons, renal oncology. So we all know each other now. So it's really nice because they can just pick up the phone and go, oh, I need some advice about this patient, or send me an email if it's a long-term patient. So, or a patient's been missed a follow-up or things like that. So it's having that good communication skills within that setting as well.
Okay, good. And so what the next question is actually probably a nice one to finish on, which is what about care home setting nephrostomy care? Is it the same? Is it different?
I mean, we would, yeah. If again a care home phoned, we would action that. So yeah, we would offer advice and again see and admit if need be. So they'd be treated the same. It's just I'm not sure what kind of support actually care homes get, and I presume it's not probably as good, but I mean, yeah, we would still offer the same advice and support for care homes.
Okay, good. I was going to have that as the last question, but another one has just come up that the only that I just think is really interesting, and this is what would you recommend for patients with it says mental capacity issues who has it says nephrectomy, which is right, nephrostomy. Yeah. So what would you recommend for patients with mental capacity issues who has nephrostomy?
But a lot with everything, it can be quite challenging, and you've got to do that individual assessment on your patient and decide what is the best management. And I'd probably, for me, I'd actually speak to consultant radiologist about that patient, because you might want to go straight for like the Munich drain for that patient rather than trying a pigtail for several times and it keep on coming out. You might assess what is the most suitable drain from the onset for that patient. But yeah, it does come with challenges, and you've got to look at your bags and how the patient's going to manage, and you need to support the patient and family members and carers as best as you can in that scenario. But it's not an easy question to answer, really. I think it's all about your assessment of that individual and assessing their needs individually as well.
Okay, well, Jenny, I think that's probably it for the presentation. As I said, for everybody watching at home, thank you very much for joining us. It's certainly been a real learning experience for me, and I hope it has been for everybody else watching at home. The lovely team that I met today at Manfred Sauer have very kindly said that you can contact them if you want to request any samples for anything that has been discussed today. Their telephone number and their email address should be showing on the screen now, and it'll be available via the slides and the presentation, which will be available on Facebook within about an hour, and on our website from tomorrow, and then on the Manfred Sauer website, no doubt within a couple of days. So do visit manfred-sauer.co.uk if you want to learn any more about any of the documents that they've got available. There should be a certificate link on the screen now and in the comments. So don't forget to download your certificate, and you should have an option in there to say whether you'd like to be contacted by anybody that's participated in the event this evening to have more information about the specific products that have been mentioned. Thank you very much to Bourne/Bown. I will get it right one day, so I do apologise if I'm saying that wrong. Thank you very much to Manfred Sauer, obviously, and Jenny. It's been an absolute delight to meet you, and an absolute joy to listen to your presentation. One of my colleagues should be sticking some more information up at the moment about a new event that we're launching in September, which is Urology and Continence Care Today, where we'll be basically having a conference to launch this new platform that we've got. So do take the details for that and come along, please. We'd love to for you to join us at one of these events face to face. I'm going to call it a night because Liverpool are playing. It's a really big game, and I think Jane from Bourne has probably got one eye on this and one eye on the football. She'll definitely be watching this, and I'm going to go and watch the second half. So, Jenny, it's been an absolute delight, as I said. Thank you very much to my team. Thank you very much to Bob, and thank you very much everybody that has watched and taken part this evening. And we look forward to seeing you again soon. Goodbye.
Thank you. Good night.